Everyone.
Perfect. Dr. Biomdo from Tharaka Nithi.
Morning, everyone.
Perfect. Dr. Muthama, the Acting Director, Machakos County. Unmute your mic, say hi.
Good morning, everyone.
Thank you so much. Dr. Irene from Kiambu County. Irene has fallen off, we'll find him. Gilo Ali from Isiolo. Gilo. Unmute him. Perfect. Jackie, Nairobi Hospital.
Good morning, everyone.
Perfect. Dr. Wagasha from Kakuma Refugee Camp.
Good morning, everyone.
Perfect. We're expecting a team from Lamu, Kwale, and Kericho as we start. So, Dr. Marybeth, University of Nairobi. Dr. Marybeth, unmute your mic. Say hi to us. Good. And our boss, Dr. Loisa Chen, say hi to us.
Good morning, everybody.
Oh, good. Thank you. Lois?
Good morning, everyone, and thank you for joining us so early. Most people logged in
very early.
Welcome to today's session. We have a very rich panel of speakers from very many counties and facilities. And thank you all to all the speakers for even taking time to prepare and join us. So we will go ahead and start. Just allow me to share my screen. Okay, so we'll just look at what our current situation is, a few of the common questions that we have been asked, and look at sort of what the global situation is and what we can do differently. So one, just looking globally, there's been still a significant rise of cases. If you look at the slide here, let me just put on, okay. If you look at the slide here and you see the global cases have kept going up. As of this morning, we're at just about 30 million cases globally. Asia is still leading, especially with the very many cases in India currently, followed by North America and South America. Europe and Africa has seen a smaller number of cases and a smaller number of deaths than other countries. And we hope this is real, that there's something about us that's actually protecting us, and that at some point we will not see any spike. But as is, I think it's something that's baffling the whole world, and everybody's trying to figure out what it is about Africa that seems to maybe be protected because we're not seeing as many cases. Of course, the question was, are we testing enough? But even having said that, the number of mortalities is significantly lower than what has been seen elsewhere in the world. If you look at the week ending or the week running up to yesterday and what's been happening in various countries. So the different colors sort of signify how many cases, weekly cases have been seen in the various countries. So if you think the week ending or week up to yesterday, what's happening? If you look at Kenya, we've had somewhere between 500 and 1,000 cases, I think just over 800 cases. Some of the countries around us have actually had more cases than that. So for example, Uganda has had just about slightly over 1,000 cases in that week. Ethiopia has had more than 4,000 cases in that week. Same with Mozambique and some of the North African countries. Looking further off, if you go to South America, Brazil has had a significant number of cases, probably close to 250,000 over the last 1 week. A little lower in North America, about 220 to 230,000. India has had probably above 600,000 cases in the last 1 week. And many countries are sort of beginning to report spikes in the number of cases that they're seeing. Looking at just African countries, I mentioned this before, Ethiopia having just over 4,000 cases over the last 1 week. Mozambique and Uganda just over 1,000. Ghana has had fewer cases. I'm not sure how much testing they're doing, but they've reported fewer cases over that time. Most of the countries in Africa seem to have passed some sort of peak and are coming down. Even Ethiopia, that had very high number of daily cases, is coming down. South America was sort of out of this graph because their cases have been so many, but they're also reporting a lower number of cases and a decreasing mortality. Looking at our own data as presented by the Emergency Operations Center, the team under Dr. Kasera, seeing that most of our increase in cases was up to somewhere around the 1st or 2nd week of August. And since then, the increase has been a little slower. We still have reporting daily deaths. So the trend of deaths doesn't seem to have changed significantly. We're still reporting daily deaths about the same magnitude as we saw earlier in the month, last month and the month before. And there has to be a question when we're still reporting deaths, is it that we're missing cases or what else could be going on? But overall, we've seen a lower positivity rate week on week. So the counties that are reporting the highest number of cases, it's still Nairobi, but over the recent few weeks, there's been a concern, one about the rising number of cases that's being reported in Mombasa, in Turkana, and a few other counties. So that's a concern. I know previously we'd say that some of the counties may end up peaking at their own time. The counties around Nairobi seem to have peaked just after the peak that we saw in Nairobi. But there has to be ongoing surveillance and very strict contact precaution in many of the other counties so that we avoid these peaks in some of these counties, especially because there's a lot of travel all around the country, all across the country. So we talked about this, I think, about 3 weeks back, and we talked about some of the issues around reopening. And I bring this up because it's a very common question that has come to us around when should we open. And what I'm presenting here is part of what the WHO criteria had been. We need to develop our own firm criteria around reopening different sectors. It may be that the house has already bolted, people have reopened without specific guidance, but even going forward, as places like schools and churches and public gatherings and entertainment joints want to open, we have to have some criteria. So one is sort of the epidemiologic criteria. So if you look at a decline of at least 50% over a 3-week period since the latest peak. So if you think of our peak coming somewhere around the 1st week of August, we've seen a significant decline in number of reported cases, and less than 5% samples positive for COVID. I think over the last 2 weeks, we've had a moving average of just about 4% of samples that are positive for COVID. But there's a caveat here that you can only interpret this positivity rate if there is comprehensive surveillance and testing. And if you look at testing in the order of 1 to 1,000, let's assume best case scenario, we're testing about 4,000. You realize that over the last few weeks, we've been testing 2,000 or sometimes even lower than that. It means that at best, we're testing just 1 in 10,000 of the population. So interpreting this issue of positivity has to be understood in that context, that our testing is not optimal yet. Then there are other issues around being able to identify clusters, that even the cases you identify, you're able to link them to a possible source, as opposed to just picking cases that you can't link, because that means that there may be clusters that you're seeing that are with contacts that are not picked up. The issue of decline in number of deaths and continuous decline in the number of hospitalization and ICU cases. And for many of you who've actually been managing the COVID units, you'll agree with me that the number hospitalized and number severely ill has also reduced significantly since August. For us in Kenyatta, we'd had so many units open around July and August, and we had so many sick patients. But over the last 2 weeks, we are actually closing some of those units because the number of patients requiring hospitalization has reduced. And even in the units that are open, the number of very severely ill cases has reduced. So if I give you an example, our unit in Bagathi at the peak had about 70 patients. And at any one time, you'd find about 30% of those patients on high flow oxygen. As of this week, we're just about 20 to 25 patients, and you'd find maybe about 30 10 to 20% of those are requiring oxygen. So we've seen a decline in number of severely ill patients in most of the units around the country. The issue of laboratory testing I just mentioned, and the issue of the positivity rate as well. So as we said, the test per population is just about 1 in about 10,000. So we're still very far from achieving an ideal testing capacity. And that will be very important going forward, especially as various sectors are open, so that we're truly able to determine where we're going and identify any surge early enough. The other issue is about the health system criteria, and we've talked about this over and over, and I think many counties have really struggled to establish some capacity. And maybe the only thing I'll say about this is that even as you see fewer cases now, it's important that your facilities are ready to handle any surge that may come. So don't drop the ball on preparedness, don't stop preparing, because preparing a facility doesn't go to waste. It can still benefit other patients, but it ensures that we are able to handle any surge that may come up. So this is important and should continue. So for example, if you look at the fourth row here, it says that part of our criteria is that the health system can absorb or expand to cope with at least a 20% increase in COVID-19 caseload. So I'll speak for KNH, for example. At this point, if you had a 20% increase in caseload, we can absorb that without affecting the usual clinical care of patients in other units. And that should be what each county, each facility is thinking about. So the other issues are around being able to conduct appropriate surveillance, being able to investigate cases appropriately, and conduct appropriate contact tracing, so that any new case should be identified, reported, and data included, for example, what the EOC gives us within 24 hours. And that should include any deaths as well. And any mortality that occurs within the community should be investigated, so that we are sure we are capturing some of community deaths as well. Where there are vulnerable groups, so for example, within prisons or such institutions, there should be enhanced surveillance to avoid any catastrophic outbreaks, and that the total number of lab tests conducted each day is reported. I think around the issue of reporting of lab tests, it's been fairly good, and the EOC has done a good job around that. We talked about case investigation, and just to go to contact tracing, that at least 80% of new cases have their close contact traced and quarantined, whether it's at home or in an institution, and that these contacts are monitored for 14 days, not traced and then lost, that you're able to monitor those contacts for 14 days. And if you look at the data that's being shared with us from the EOC, the red is cases that do not have any contacts listed. The green is where contacts are listed. Whether they are followed or not is not clear, but at least there's a list that indicates the contacts. And where no contact has been listed. So you can see we're still a little in the red and very little in the green where all contacts are listed. So clearly our surveillance criteria for reopening has not been achieved, and this is one area that needs to improve significantly. If you look at number of days pending contact listing, so the red is 8 to 14 days, which means if someone is positive and for 14 days you're not able to get the contacts, by the time you get those contacts, they've already had so many other contacts. So that's an area that needs to improve significantly. The next thing is sort of what are we learning from other countries? As I said, some of these countries may be different, and if there's anything we've learned over the last several months is that we cannot really predict where our own situation is going, because we don't seem to be following the predicted curve. But having said that, we cannot close our eyes to what other countries may be going through. So as I said, in the last few weeks, we've noted, if you look at this, are you seeing my cursor? Okay, so if you look at this row that I'm pointing at, for example, if you look at India, they have a large total number of cases, but they've also had, just in one day, they had close to 100,000 new cases. If you look at Brazil, again, with several thousand new cases. If you look at some countries that seemed to have, sort of controlled and had started to reopen. So Israel, for example, did not have that many cases. But as of yesterday, they had about close to 5,000, and the day before they had close to 7,000 new cases. And they're actually going back into a total lockdown, I think starting today or in the next very few days. If you look at countries like Spain and France that had, done a lot of reopening, they're now reporting close to about 10,000 new cases. So what this tells us is that any reopening really has to be handled with caution. There needs to be ongoing surveillance so that any surge is picked and taken care of as time goes on. So for us, what we're not clear about in the African context is there anything that will help us predict whether we will have a second wave after reopening, especially because our curve doesn't seem to have followed that's seen in many of the other countries, and will African countries actually experience the same? So these are questions that still remain unanswered, but I think one thing is clear is even with reopening, we'll still have to continue maintaining certain measures. For example, universal wearing of masks and maintaining of the hygiene practices, and as much as possible, avoiding public gatherings. Thank you very much. I will stop there and invite our next panelist, Dr. Sood, if you're there.
Yeah, thank you, Lois. Thank you, Lois. Well, thank you very much, Lois, for that. And a lot of things are actually also replicated here, and I will show you how. So in Mombasa currently, we just have a total of 9 patients. And out of these 9 patients, the 3 are the ones who are positive. And they are the 3 who are also in ICU. We have 2 males and 1 female. And we have suspected cases, which are 6. And our cumulative home-based care is actually 138 now. The patients who are at home-based care, 72 are males, 66 are females. And we have negative tests of 90. But now, since a lot of patients understand that when you are in home-based care after 14 days, you are okay. You just need to continue with the mitigation measures of wearing mask, social distancing, hand washing. So a lot of them don't come back for tests, or even when we request to do the tests, they say they're okay. They are following the guidelines, what they are being told. So finished 14 days at 35. We have only 13 currently at home-based care who are still on follow-up. I wanted to share with you these 3 people who are in ICU, and you can see the numbers might be coming down, but the severity in these patients still remains the same. Now look at the patients. The first patient is a male, the second one is a female, and the third is a male, but they have a couple of things which are going to be running across. Their BMIs, 37, 35, 38, diabetic, hypertension, and diabetic again. And you can see, even if you are young, but you have these comorbidities, you can actually have complications. Now, they are doing well. They came in with saturations of 70. Currently, the saturations are 95. One of these patients here, we actually used one of the drugs as a compassionate patient who we signed the documents with everything, and is responding very well now, and is doing okay. And all these patients, we are actually just putting them on high nasal flow cannulas. This week we had a patient who we had intubated for the last 3 weeks. Unfortunately, we lost her 2 days ago. So we are seeing patients, if you manage them early with your high flows, with your cover with your low molecular weight heparin, your Dexas, and some of the other medications if needed, they do well. Now, also there was a couple of questions being asked. What about the outcomes of these patients? And you can see there were many deaths in the beginning, but then now we are almost stable. We are not getting more deaths occurring. And this is actually even in Old Town, the place where in the beginning we did quarantine. This is what we are seeing now. This is also true to see how the number of patients is also coming down. And we always get a question, is this a true thing? Are we doing tests or are we just making up things? So I decided to give you a data for 15 days just to show you that however much we are doing, 600, we are getting 17 cases. You can see we did another one here, 715. We got 6 cases with a positivity rate of 0.8. I think when we started panicking is when we clocked 43 here, and we thought now we are being hit by a wave, but there are reasons for this 43 is a lot of companies actually came out to test their people who are traveling out. We are getting a lot of patients coming from different counties, coming to seek medical care at our facility, and we do test them before undergoing surgeries and the other procedures, and you can find the numbers actually went high, but you can see again on 15th we did 464 cases, and we still got 2% positivity rate, and if you do the average, we are actually around 3% in terms of positivity rate. Of course, there are days we are doing less numbers because we have a low number of people showing up. We have had problems with VTMs also. Currently, we don't have reagents, so we are sending our samples to Cambridge. Of course, there are some challenges which are still there, like the referrals I just talked about. These are some of the referrals which we find coming from different counties, and when we do the tests, they become positive. Home-based care, we do get patients who require negative results to be allowed to return to work, and I think this needs to be addressed maybe at the Ministry of Health level to allow some of the people who have self-quarantine or isolated at home to be allowed to go back, because it takes time, and currently we are also having challenges, so it becomes very difficult. Of course, in terms of cases, not generating contacts, because we get false informations. People are giving us numbers which are not correct, because till now at our facility we are doing the test for free. We are not charging, so you can just walk in and come to the tent and you get your test done. Of course, we have a few VTMs available. As I said, we don't have reagents currently, so we are sending the samples to Kilifi, which is also affecting our turnaround time for these patients. And then the last challenge, I think, is the burial guidelines. We have seen a guideline from WHO, and a lot of people now coming in telling us the WHO guidelines say that the patients who are dead don't need to be put in body bags, and you know, so a lot of confusion is really taking place, and sometimes we get orders which are necessary, but I think we need a guideline so that all of us can operate at one particular level. So I just want to finish with this, and you can actually see that it's not only about sick people, it can affect anyone. And I just showed you a 34-year-old who's actually in ICU. So I would want to stop there. Thank you very much.
Thanks, Dr. Sood. I think mine is still just a concern. There seems to be a rise in your positivity rate, you know, from a low of 0 point something at some point to reporting close to 9% on some days. And I'm just wondering if these are patients who are coming in because of travel or because of work, then it means you're also picking cases in people who have a low pretest probability, low risk patients, not necessarily sick patients. And I'm wondering whether how well you've been able to identify contacts, because these are the ones who transmit to the sicker ones. And I think as more and more travel comes towards Mombasa, either from out of the country or within the country, you still have to keep a very close watch on what's happening in Mombasa.
True, Lois. I agree with you. I mean, some of these patients are just walk-ins with no signs, no symptoms, and they just want to run a test. And sometimes we are given false information too, but we can't verify it. If a patient tells you, I had a contact or one of my neighbor was positive and I need the test to be done, so we have to do it for them. In terms of the people who are coming in, also now we are seeing the elderly patients who are coming in really sick, and some of them actually are positive, but they are mild symptomatic. So we still try to sensitize people and tell them that we are still there. However much we are saying the numbers have gone down, it is still a high risk for elderly patients.
Okay, thank you very much, Dr. Sood. We'll now invite Dr. Irene from Kiambu County.
Good morning, everyone.
Good morning. Go ahead, please.
Okay. On my screen. Unfortunately, I'm usually not able to go on slideshow, so I'll be very, very brief. So my name is Dr. Irene from Kiambu County. Sorry. So I'm just going to briefly on statistics. So far, we've had total number of cases 2,650, and we've managed and discharged 381 cases from the hospital. Our total number of deaths stand at around 105, which gives a case fatality rate of 3.9%. We have had patients undergo home-based care, and so far we've had 1,167, and we have successfully discharged around 831 patients, which means around 300 patients are still under home-based care. Currently, we only have 11 patients admitted in hospital, with only 5 of these patients being on oxygen. We've had to close most of our holding areas and isolation wards in other facilities. For example, in Kiambu, we've not had a patient in the holding area for the past 1 month. However, we've had, I think I can say a few good things have come out of this pandemic. For example, for the first time, now we have 5 oxygen in the wards. That's for Kiambu level 5. Currently, as we speak, there's an 8-bed ICU coming up, and the isolation unit which used to hold the holding ward is going to be converted into a renal unit. Migori has also benefited by extension of the hospital capacity to around 74 beds, and this is projected to increase to around 300 by the end of the year. They've also had oxygen piped into the facility. They've also had high flow nasal cannulas and ventilators in the facility, and that also includes Kiambu as well. For other county hospitals, Thika is expanding their capacity to around 16 beds, and Gatundu will have 8 beds. Wangige will be extended to a 100-bed capacity, and this is projected to be 200 by the end of the year as well. We've also had Ruiru being extended as a result of this pandemic. In terms of capacity building among healthcare workers, right now interviews are going on for critical care nurses, anesthesiologists, medical officers, clinical officers, and other cadres such as physiotherapists and public health officers. So I was looking at data regarding our cases. I decided to concentrate on 2 communicable diseases. So that is TB and diarrhea. So after the pandemic, we had a 74% decrease in the outpatient TB cases, and a 62% decrease in the outpatient TB cases in the people who are over 5 years. So we don't know whether this was because people were not coming back to the hospital, or it was because now people observed social distancing measures. The diarrheal cases in the under 5s also decreased by 85%, which I think probably because of hand washing and other hygiene measures that people have undertaken. However, there was a 26% increase in diarrheal diseases in the people who are over 5. So again, you're not too sure, well, was it because children were now at home and interacting a lot with each other, which still also happens in school, so it's quite not clear why that happened. In the inpatient department, TB cases went down by 38%. That could also be explained also by the decreased number of patients. We also had a 50% decrease in admissions due to diarrhea. As regards challenges, well, we still have challenges. Test kits are becoming a problem. Most of the times we don't have test kits. We are also unable to trace contacts, mostly because some have either switched off their phone, or the patients are usually don't give clear information. We also have issues with finances to support activities. As you know, there was a stalemate with allocation of revenue. So really a lot of our field activities have really stalled. And then the last challenge we're having, of course, is healthcare worker fatigue. We've been working without going on leave. And I think a lot of our healthcare workers are getting fatigued. I think that's it from me from Kiambu County. Thank you.
Thank you so much, Dr. Irene. I think you should stop being tired now that you have few patients before we see any other surge. I encourage people to take leave at this time. But thank you very much for that presentation. And it's really exciting to see that you have bulk oxygen storage now. And I think one of the good things that we'll get out of COVID is that our healthcare workers will be, healthcare facilities will be better prepared to handle critically ill patients. So I hope you accompany that with good critical care training for your healthcare workers so that you have more critical care nurses. That's something you really need to build on, just like every other facility in the country. But thank you so much for that presentation. So many times over the last few months, we've always wondered what may be happening in refugee camps, vulnerable populations where there's a lot of crowding perhaps. We've had a few presentations from the team in Turkana, but never from the team in the refugee camps. And today we are very privileged to have with us Dr. Barton, who is a senior public health officer with UNHCR, and will talk to us about some of the issues around care of refugees. Karibu, Dr. Barton. We already have your slides on the screen.
Thank you, Royce. But I changed a bit, a few points. If you don't mind, let me share what I have. I will submit it to you later on. Maybe you can pull that down. I present what I have.
Oh, no problem. You can share your screen.
Excellent. You can see it now?
Yes, we can see it very clearly.
Excellent. No, thank you very much, and thanks for inviting me here. This being my first time to come, I may take a slightly different approach from the rest of you. Maybe in the subsequent meeting, I'll be able to provide very brief updates. But I want to really start by enlightening the team on what is unique about the camps and why we should be concerned or maybe adopt a different methodology for controlling COVID. The Kenya has two main camp complexes, Dadaab and Kakuma, with a total of just we're about over 400,000 population. Luckily, majority of our population is young, with over 70-75% actually below 30 years, and only a very small proportion of the people are old. The camps are unique in terms of a high congestion, and if I use the population density to elaborate this, if you look at Nairobi with a population density of 67 persons per kilometer square, and then you compare that with both Dadaab and Kakuma, because the space given to the refugee is standard, and therefore we are talking of almost 80,000 people per kilometer square. And that is an area view of one of the camp, and the facility that you're seeing here is one of our major COVID-19 isolation facility. It's called Evo 2. It was a hospital that we were using for regular situation, but now has been commissioned to only deal with COVID patients. It has a 100 bed capacity. In terms of statistics, we can see where we fit in the country and in the county. The refugees are hosted in Turkana and Garissa County, and you can see in the total number of cases in Turkana County 2 days ago, or yesterday, about 176, 75% of them come from Kakuma refugee camp, where we have witnessed a case positivity rate of 6.5%. The Kenyans are actually few, but you can see also the humanitarian workers are really carrying the burden of the disease. To the contrary, if you go to Garissa County with almost 350 cases, the contribution from the refugee camps is much smaller. It's about actually 25%, with the majority 272 coming from the host community. These two aspects are very important because this is an expression of high movement of the Somali community between Nairobi or Isiri and Garissa, whereas on Turkana side is a reflection of how difficult it is for the host community to travel, but then the interaction and the new arrivals from Southern Sudan and other cross-border movement are really giving a heavy toll on the cases in Kakuma. On the urban, this is an integrated population. I don't need to say much about it. Our approach on COVID response we have really had a lot of discussion between the MOH. We've had several meetings with both the CAS, but also the National Operations Center, and also other team there. And we really had to look at how to shield the camp. And when the country had put the restriction of movement, including Nairobi lockdown, the government had also put a specific restriction of movement in and out of the camp, because the government understood the situation of the camps. The Ministry of Foreign Affairs has also been extremely supportive, and recently they released a special protocol on movement of humanitarian workers, which lay emphasis on need to shield and protect the vulnerable population like refugees. And this is also guided by the Kenya government humanitarian agenda when they were fighting for their post in the Security Council. And therefore, our approach has simply been on prevention. And because we know that if the numbers increase in the context that I've explained to you, then we are likely going to be overwhelmed. We started, of course, by working with MOH, CDC, Kenya Red Cross, and others to train and sensitize community health workers. Luckily, in the camps, we have a wide network of community health workers, community health frontiers, and health promoters who are located blocks. And we also have the block leaders, religious leaders, and the camp being a very confined area, it is possible to walk from one corner of the camps to the other within an hour or so. But the role played that by the Kenya police on surveillance, both from security point of view, but also trying to capture any new arrival, really helped us, because we are able to quarantine everyone that came and also did the testing. We really wanted to prevent the COVID from reaching the camps. And by so doing, there was what I mentioned, the specific Kenya government gazette notice restricting movement in and out of the camps. We've had a controlled humanitarian workers movement, where we, even today, we don't allow people to go to the camps if they have not had COVID-19 free certification. We also banned and stopped any humanitarian mission. You know, camps attract a lot of international missions, sometimes what you call the humanitarian tourism, people who just want to come and see, journalists and others. We have really restricted that to see how far we can be able to prevent spread until we are fully prepared, because there are still some steps that we have not put in place yet. We've been working with the police and IOM and other partners on border surveillance and strict quarantine of the new arrivals for the 14 days, and also did the COVID screening. The DAB has been unique because majority of the cases you saw from the DAB, 90% or so are from the quarantine among the new arrivals. We've also been really done very well on contact tracing. The quarantine, we learned a lot from it, because for you to succeed in quarantine, and we learned some good lesson, is that you really have to know what people value most. People running from hunger or danger, being able to provide them with a shelter plus 3 meals, and also something that psychosocial support within the quarantine facilities made it possible for them to want even stay much longer. We also looked at the drivers and areas of risk in our operations. And we know that people cluster in thousands at food distribution points, and water points every day, but food distribution point is unique because the whole 100% of the population will have to gather around 2 or 3 distribution points, and we had to do more there in terms of COVID screening for the food scoopers, but also maintaining social distance in those areas in line with the MOH guidelines. We had also allocated the community health workers some blocks and household where they visit every day with MOH case definition for active case finding, but also to do other awareness creation. We are doing a lot of triaging and trying to really look for any case that can fit case definition at the health facilities. And once we are able to do more testing, we will do much more in the health facilities as well as at hotspots areas. In terms of the response, we do not have ventilators, but we have procured mini oxygen concentrators and sprinters. Each oxygen concentrator can provide oxygen through the face mask with the nasal cannula to 5. If we had stronger one, we are still trying to see whether it can support 10, because with the double bottle can actually provide oxygen to up to 10 patients at a go. I mentioned to you that we have isolation facilities in Dadaab. I talked about the 100 bed capacity, but in the camps, there are small isolation facility 20 and 10, meaning Dadaab we have the 130 bed capacity, and Kakuma we have 66 plus 12, that comes to 78. But we have also converted some boarding schools to expand the isolation capacity should the cases increase. And that is how the isolation facility look like. We have also looked into our commodity supplies, and we really also got a lot of support from also KEMSA, and then ongoing noise notwithstanding. I think we realize that KEMSA is quite efficient in terms of logistics and timely provisions of the commodities that we do need, even if we are not able to get a PPE, but at least all the other commodities. For when we started going through the KEMSA, we were able to get a lot of support. The other important aspect for us is that we have been working in integrated manner with the counties. We have been avoiding this one parallel system for refugees alone and a host community. And now we have an area-based approach, which is an integrated approach where we try to meet the need of both the refugees and the host community. A few lessons that we have learned. If you look at the situation I presented, Kakuma and Turkana, Garissa and Turkana, means that for us to be able to address this pandemic and in the future epidemics, it is very important to understand our population dynamics and drivers of epidemics. For me, from where I start, I think Kenya is not a homogeneous area in terms of outbreaks and pandemics. And there are some areas of this country which we could have shielded and survived without cases even now, because majority of the affected counties are those which I would consider interns of the city. Of course, we could have, those are just some key points, and I don't need to go through them in the interest of time. And I really want to appreciate, I drew a lot of my notes from the data from the Ministry of Interior, Refugee Affairs Secretariat, the MOH, the UNHCR statistics, the MOVA Special Protocol, and our partners, Kenya Red Cross and IRC. And thank you very much. And over to you, Royce.
Thank you very much, Dr. Burton, for that very comprehensive presentation. I think it's impressive the level of preparedness that you have even in the context of the difficult circumstances that you have to work in. I'm just wondering, for the patients you have, the many positives that you announced recently, where are you managing them? And do you have a place where you admit everybody irrespective of symptoms, because it's so difficult to have home isolation? Are they all in this facility, or how are you going about it?
Our 80% of the patients in Dadaab have been admitted in this facility, and the other 10% in the other two facilities, but we still have about 10% who remained at home, and apparently they had. When you look what you see in the background there, they may look like isolated houses, but if you go closer, you see their homestead with 4 or 5 houses fenced together. So what you are working with the community, because you know this facility will be overwhelmed, is to identify one of the houses out of the 4 or 5 in a homestead where a positive case can stay. And we are doing this when we do not have many cases, to prepare the community for home-based care, because we realized that when we brought everybody to the facility, it was also difficult to integrate them back. And we really need to start working with the community to see, to reduce the stigma towards the disease. So we still have 10% who are taken care of in the community, but right now, because we are not overwhelmed, the majority of our cases are going to the facilities. For example, this one that I've shown you, and this is a Kakuma facility.
All right, thank you. Yeah. Thank you very much. I mean, the level of preparedness is impressive. I'm just wondering, what is your projection? Given that you started to pick slightly more cases than previously, where do you think this is going to end? How soon are you able to remove those who are infected from the population? And how well are you managing to trace the contacts and quarantine those contacts, even if within their homes?
We wanted to really have a testing platform, and we had also promised to support the Garissa and Turkana County. We raised the requisition to buy 4 GeneXpert machines and 33,000 test kits to start with, but this has been very, very elusive since July, when we raised the requisition and committed that money. We are now told that the GeneXpert machines may be here in another week or 2, but we will only be able to get 5,000 test kits, and that is what we may also share with them. Like, for example, Turkana has not been able to test anyone this week for lack of anything. But then the next week, we are going to get about that 5,000 VTMs, which we can use to do more targeted testing. In Kakuma, for example, we have what you call Kakuma 1, which we now have identified as a hotspot. We need to do more targeted testing, and then we isolate all the positive. We have 5 more schools which you can already convert if the one that we have are full. Our plan is to do more targeted testing or the contact tracing, because contact tracing for us is not a problem, because we are dealing with a confined population. They don't get out of their homes to go to travel, and we can be able to get every single contact within a few minutes, not even hours. And therefore, our main challenge is testing capacity, which is indeed frustrating because of the global shortage that everybody is experiencing. We are also able to quarantine them for 14 days because WFP is able to give us all the food that we need, and we have made arrangements for wet feeding for those people in those facilities.
Thank you very much, and thank you for even just opening our eyes to some of the work that you're doing, which is really incredible. Thank you for making time to make this presentation. So allow me to move on to another facility. Dr. Ruth Muthama, are you there? Dr. Barton, kindly pull down your presentation.
That's what I'm trying. That's what I'm trying to do. Give me a minute.
All right. Dr. Muthama, are you there?
Yes, Dr. Ruth, I'm here.
Oh, sorry.
Karibu sana. Dr. Muthama is the Acting Director of Medical Services for the Machakos County Government.
I don't know. I'm struggling, Royce, to pull down.
Is there a red button that says stop sharing screen?
Oh, yeah, I've seen it now.
Yeah, so click
Thank
on
you.
that one. Okay, thank you so much, Dr. Barton.
Thank
Dr.
you.
Mutama,
And it
karibu.
was pressure to invite me, and I'll come again when I'm invited.
Oh, excellent. We will invite you again.
Thank you very much, Dr. Lois and team. I'm giving this presentation on behalf of the County Executive Committee Member for Health, Machakos, Dr. Ansent Kituko. First slide, and Dr. Thuranira, kindly, first slide, where there's a photo. In Machakos, we have a very good political will. Here we have His Excellency our Governor posing for a photo with a health executive. I can see our Waziri there and the frontline health workers. This was after he launched the Machakos County COVID-19 Field Hospital. This hospital has an outpatient facility where we are doing screening and an inpatient bed capacity of around 300 beds. Next. Next. Yes, our cases started picking up in the month of June through July to August. And then in September, they have markedly gone down, and we are very proud of that. Next. Next slide. So looking at the current situation, we have cumulative facility admissions of 185, cumulative home-based isolations of 344, cumulative recoveries of 501, cumulative deaths of 44, and current admissions, currently admitted, we have 13 cases. These cases are home-based isolations. We have actually, as at now, we have 0 cases in our isolation facilities. Next. Looking at the cumulative cases per sub-county, Machakos County has 9 sub-counties. Most of our cases are in this sub-county called Mafoko. Mafoko is also called Athi River sub-county, and this sub-county is part of Nairobi Metropolitan, which actually is part of Nairobi, and we have, most of our cases are here, 1,053, followed by Machakos sub-county, which is our headquarters, 183. The rest of the cases are concentrated in other sub-counties, giving a cumulative total of 1,325. Next. Looking at the distribution of cases by aging groups, you realize the most active, economically active group is markedly affected from 20 years through to 60 years. The youngest was 1 year, the oldest 97 years. Next. Distribution of the cases by gender. The males are more affected than females, slightly. And I think this is a reflection of even what is happening at the national. This is basically the summary of what I'm trying to give to us. As I said, our total cases are of 1,000. Currently, the active cases are 13, recoveries 501, as I had said. Total deaths, we have 44. Of course, we have deaths that are happening outside the county and others within the county. Yes, most cases die outside the county, then we conduct the burials. Looking at the testing capacity, we have tested over 10,000. Over 10,000. Those are the positive cases. Our isolation bed capacity is 575. We have isolations in Machakos, isolation facility in Machakos level 5, Kangundo level 4. We have our field hospital. And as I said, right now, our hospital admissions are 0, home isolations are 13. Something to note, we have 2 hotline numbers which are operational. So those 2 COVID-19 hotline numbers are very operational. Next. Next. Looking at the numbers as far as home-based care is concerned, we've had cumulatively 346. And if you look at the concentration, most of the cases are in Mafoko sub-county, as I had said, and Machakos sub-county. And as I had said, currently the active cases are 13, and that is the distribution. Next. So this is our field hospital. It is very beautiful. And as I said, the bed capacity is around 300 beds. Our patients are watching the screen as they are being seen by our frontline healthcare workers. And this is common across all our facilities where our patients are able to watch the media as they are given the care they need. Next. Before I leave the field hospital, we are thinking of closing the facility because the cases that we are getting currently are able to be accommodated in the isolation facilities that are in our hospitals. Now, looking at the laboratory testing, our lab is in Machakos level 5 is accredited for COVID testing. This has really helped us to shorten the turnaround time. We are able to get the results within hours for the priority groups. That is the suspected cases and the primary contacts. We are able to run around four rounds. So in 24 hours, we are able to get over 100 results in 24 hours with very good, well-trained staff. So we have a network where the samples are collected from the sub-counties, then they are moved to the lab where they are tested, and we are able to get the results within the shortest time possible. Our public health teams in the community are doing a very good job. In every sub-county, we have a rapid response teams that are tracing our cases and the contacts, and they are doing other public prevention measures like in the contamination of public spaces and hospitals and some institutions. Next. Next, Dr. Tharanira. We were very happy and excited to get this machine. This vehicle is helping a lot with the surveillance activities, which we got through the support of MOH and the World Bank. And as I said, the surveillance teams are very active in the community. We've been able to conduct several COVID-19 barriers, and our staff is very excited. They have gained capacity from identification of cases to the last respect. So we've conducted a number of these barriers, but right now, after the change in guidelines, the public health teams are observing and equipping the community to do their own barriers. Community outreach, we are doing a lot of community outreaches. There's a lot of health education taking place in the communities. Our community health volunteers are all trained to give health education and do tracing for us in the community. We have over 280 community units and almost around 2,800 community health volunteers that are assisting us. And still, before I move forward, outreaches, we have done some mass screening in some institutions, and we have over around 75 ambulances. We've dedicated some for COVID referral, and others are helping a lot in the community as far as surveillance activities are concerned. Looking at our staff matters, we noted that our staff were getting burnouts. So this is one of the innovations. We've started what we call Zumba sessions. The staff are able to dance out their stress. And here the management is also involved. You can see we are all wearing scrubs. And during this one session, we had a trainer, and these sessions are still ongoing. In Machakos County, we really appreciate and we are embracing partnerships. Every partner who is coming in to support a COVID-19 response is being received at the desk of His Excellency, our Governor. They explain what they are coming to do, and then they are directed to the relevant departments. In this photo, we have a group of youths that are communicating prevention measures to the community. If you are able to read some of those posters they are holding, avoid touching your mouth, eyes, and nose, keep physical distancing, and the like. So currently we are emphasizing on prevention measures, and we've been having weekly COVID reporting meetings. We believe in Machakos County we are winning, and we are going to win this war. Thank you very much.
Thank you so much, Dr. Muthama, for that very clear presentation. I think you did a very good job in terms of getting prepared and managing the patients in a really good environment. So good job to you and your team. I guess only one comment that I wanted to make. A few places have sort of set up these field hospitals. I don't know what your experience has been in terms of cost versus the long-term benefit. I think one of the discussions we'd had in different fora was that instead of setting up field hospitals, would we pick up smaller hospitals and pump that money into structures that would outlive COVID? And that was always difficult because these were things that were needed immediately. But maybe with time people begin to reflect on the cost versus the long-term benefit of whichever investments have been put there when we put temporary field hospitals. I don't know what your thought on that is.
Well, of course, the cost implications are there, but the initial consideration was the impact. The main reason was to make sure that we manage COVID cases effectively as we allow the other activities to continue. Because if we were to accommodate them in our level 5 hospital, it would have really interrupted the routine cases. So if you look through our indicators, we are not markedly affected by COVID because we were managing them in different facilities. If you look at the distribution of our isolation facilities, we only have 11 bed capacity in the level 5 hospital, and in 2 other hospitals, Kangundo level 4, which has 14, and Kinania, the center, which has around 10 bed capacity. And then the rest of the county, we have holding facilities. So if we were to rely on the hospitals, we would not have managed the COVID. But I think from other sources, managing finances.
Thank you, Dr. Muthama.
Thank you.
Okay, thank you very much, Dr. Muthama. Very well answered. And it really just reflects the difficult decisions that people had to make in the middle of a crisis. Allow me now to invite Dr. Biomdo. Dr. Biomdo is from Tharaka Nithi, and this is their first presentation. So we are very grateful you could join us, Dr. Biomdo.
Thank you very much. Let me share my screen. Good morning, everyone. I hope you can hear me loud and clear.
Yes.
Thank you for this. Yes, thank you for this platform. My name is Dr. Irene Biomdo. I'm the physician in Chuka County Referral Hospital, and I'm also the in charge of the isolation unit in Chuka Referral Hospital. So currently, Tharaka Nithi has 4 isolation units. That is the Chuka County Referral Hospital COVID unit, Marimanti, Magutuni, and Chogoria Mission Hospital. But the one that is currently active is Chuka, the one now that I'm heading. And our infrastructure, we actually have a 68 bed capacity. Our holding unit has 8 beds. This is where we keep our suspected cases. The isolation unit proper, the one we began with, has a capacity of 10 beds. And following the Ministry of Health guidelines that we should expand to around 300 beds, Chuka Referral Hospital converted a new pediatric unit, which is our extension unit, to hold at least a 50-bed capacity in case of any surges. And we're also lucky that we have an oxygen plant, which we began a few years before, but because of the COVID pandemic, we expedited the process. So this is how our isolation unit proper looks like. It has a 10-bed capacity, and it's currently the one that is active. And this is now our extension unit. The one with the yellow label is the new pediatric ward. It holds a 50-bed capacity. It also has a space for ICU that we hope that we will be able to, we'll be able to develop in the near future. On your left is our withholding unit, or our holding unit, where we keep our suspected cases. It also holds an 8-bed capacity. So this is our oxygen plant block. We began it several years ago, but we expedited it during the COVID-19 pandemic. We are able to bring in our oxygen cylinders and refill them here, but unfortunately we have not yet piped it into our wards or our isolation unit. We are still awaiting some funds, and hopefully maybe sometime in the near future we'll also be able to do the reticulation process. So I want to introduce you to our isolation unit staff. We have 8 nurses. One of them has done renal care. We have 6 clinical officers, 3 lab officers, 3 PHOs, 2 support staff, 1 medical officer, 1 driver, and a physician, that's myself. We organize ourselves into 4 teams, team A to D, and we are accommodated in a hotel nearby. And we do shifts in terms of team A, shifting with B, C, and D. And yeah, it has worked very well for us. So in terms of our testing, Tharaka Nithi has tested a total of 1,100 cases as per Tuesday this week, though we have done others towards the end of the week. 47 have turned positive, the youngest being 13 years, oldest being 65 years of age. Those that we treated in the isolation unit were 16, and those that we catered for in the home-based isolation care were 25. Unfortunately, we've also seen 6 mortalities. And out of the 47 cases, 38 were asymptomatic and 3 were severe. Just to mention, for the mortality cases, we saw 3 community deaths. And the 3 that we also encountered were in hospital. 2 were in the hospital before they moved to the isolation unit. They didn't even stay 24 hours. But 1 was in ICU in our sister hospital, in a mission hospital, which has now the ICU unit. So this is where I want to now bring in our unique story for Tharaka Nithi County. We have been doing targeted testing and testing for symptomatic persons. So for targeted testing, we have been targeting the remandees. It's a requirement for us to do so before they are transported, or rather referred to Embu for cases that have a higher penalty. We are required to test remandees, and in case they are positive, to handle them. We've also been doing targeted testing for hospital staff. I've mentioned that 2 were in the general ward, didn't finish 24 hours of testing, and they turned out positive, and those were mortalities. Also, institutions like banks, Huduma centers, they approach us and they request us for the same, and we do testing for them, and hoteliers. And of course, we do for symptomatic persons. So I want to share this story for remandees because it's a question I also asked in this forum. These are patients who tested positive in large numbers. You could have 11 today, 8 tomorrow, so on and so forth. And it brought a contention in the Department of Health in that sometimes even the turnaround time, by the time you get those results, 10 days, they've already finished. I mean, you get the results 10 days afterwards, meaning that they've already finished their recovery period and they're still in their prison cells. So it was not easy for the police force to understand this issue of 10 days, 14 days isolation period. And yes, it brought a tug of war, but we considered as a county and we isolated them. We went ahead and fumigated and disinfected these prison cells. We even offered a free mini medical camp there. And we also offered testing for the police officers. So as we considered and isolated the remandees, there was lethargy from the police force to have them discharged without negative results. And you can see sometimes the turnaround time for testing can be 2 weeks, can be 3 weeks. And herein lies the problem that we've had. We've had testings, repeated testings, and sometimes even the remandees still test positive a month later, 6 weeks later. And now we still keep them. But this is still in discussions, and we hope from this forum we can also get some advice. The other unique story we've had, as I mentioned, we test our hospital staff. This was because we had 2 mortalities of our patients who were in the general ward, and a few did test positive, and they went on to home-based isolation and care. They were asymptomatic. And yes, we do voluntary testing that is ongoing in the hospitals. I think Tuesdays and Wednesdays are for staff only. We have an ongoing disinfection and fumigation of the wards, such that if there's a healthcare worker that has been found positive in the medical ward, then we fumigate it again and shift like that. If it's maternity, if it is pediatrics, and the same. We've also started restricting visitors to the hospital. And this is what now made us have a withholding unit or a holding unit, where at least suspected cases can move from the outpatient straight to the holding unit. They don't have to go to the medical wards. Now, our other unique case was the symptomatic patients. I'm happy to say that we handled 3 patients with COVID pneumonia. 1 patient was actually hypertensive and diabetic. We did not lose them. They recovered, they did well. And what we used was high flow oxygen. We don't have the high flow nasal cannulas yet. We use nasoprongs. We also use face masks, non-rebreather masks, and we give them supportive treatment and nutritional support. The case I'm mentioning for a hypertensive and diabetic patient, yes, we had issues controlling his sugars and blood pressure, and we just handled the complications as they come, and as I'm speaking today, is ready for discharge. The challenge we've had is limited support lab investigations. Our inflammatory markers currently that we are using, to be honest, is ESR. We also use the full hemogram, and of course our baselines, kidney function tests and liver function tests. But it would be good if we had CRP, D-dimers, and the other markers of inflammation. In terms of imaging, we've been doing chest x-rays for all our suspected cases. We hope to move to CT scans. And this is just in consultation with the radiology department, because as you all know, sometimes there's that fear and anxiety when handling suspected cases or confirmed cases. So as I finish, I just want to report on the challenges that we have. And I'm happy Dr. Sood has mentioned this. One challenge is return to work formula for these healthcare workers who are still testing positive, or any of our patients that you manage. They do well, they become asymptomatic, but they still test positive. The same for remandees. It's really a challenge explaining to the police force that now these patients are not shedding the virus, possibly. They're not infectious. They finished 21 days of isolation. Kindly, we can discharge them. So there's really need to at least disseminate information as when to, to the police force and also to us as healthcare workers, when do we now return to work? for those healthcare workers turning positive or the remandees to be discharged. And I was also thinking maybe a special framework for asymptomatic remandees, especially in the prisons. I wish they could all have quarantine centers. Then maybe healthcare workers can go and visit them and help them. And in case that doesn't happen, then I think it should be very clear that then we should isolate them in our hospitals and treat them like any other. Yeah, the other is availability of remdesivir to the counties. I know Dr. Cheng can comment on that. Then we also are experiencing stigma. We are rather seeing stigma in some of our patients who could be of, can I call it a middle upper class and the upper class, whereby—
Okay, Doc, please finish up.
Yeah, whereby sometimes the contact tracing can be a bit of a problem and they don't give us the real information. And then last but not least, the fundings that sometimes can be diverted elsewhere. So those are our first patients that we managed and were able to discharge them. And that's about my last slide. Thank you for the opportunity to share what we have in Tharaka Nithi. Yes.
Thank you so much, Dr. Biomdo. You take us back to when we first started, and we also struggled with what to do with remandees, what to do with healthcare workers. So maybe just to try and shed some light on some of the questions you asked. One was how to deal with remandees, especially where you have such a long turnaround time. That has no easy answer. It's something that we have struggled with quite a bit over the last few months. Whenever there's a delay, it means you expose a lot more people. And maybe you can work with a police service to look at their remand facility and say, can they put patients, not patients, what are they called? Remandees who come in a separate facilities rather than mixing them with those who've been there for longer. And also separate those who may be symptomatic. So hopefully they have the capacity to do that, because that may be the only shortcut, even as you work around the challenges around the testing. The same applies for within the hospital, that you should be able to cohort patients so that patients who have any symptoms of respiratory tract infections are cohorted together rather than put into a ward that has 50 other patients, so that in the event that someone turns out positive, they will not expose several patients. And this now will include other changes like really trying to limit visitors, ensuring your patients are wearing masks, and are talked to about the issues of transmission. That may be the only way to slow down the transmission within the facility. For the issue of healthcare workers, we've discussed it severally on this platform. And I think we've shared the evidence for the 10 days and also the guidelines around 14-day return for healthcare workers without necessarily requiring a repeat test. As well as guidelines from other parts of the world that have supported the same. So that's what we'll continue to do. There's just one thing I noted. You had 6 mortalities for the 40-something confirmed patients, which is an almost 12% case fatality rate. And I'm not asking you to answer now, but it's something to think about, because that's relatively high. And you may really want to think about, was it about delayed identification? Was it about issues around management of severely ill patients, so that you even reduce that number? Thank you very much, Dr. Biomdo, for that presentation. Allow me now to invite Dr. Ian from Migori County, my former home county. Dr. Ian, karibu. Are you there? Dr. Ian? Okay, as we try to find Dr. Ian, we have Dr. Jackie Odhiambo from Nairobi Hospital. Jackie, you can go ahead.
Okay, let me share my slides. I'm not able to share my, okay, sorry. Can you see my slides now?
Not yet.
And
okay.
Now?
Yes, we can see them now. Thank you.
Okay, so in the interest of time, I'll just go straight to my presentation. Mine was to present a case of one of the patients that we've successfully managed. And the reason why I picked this case is because it's a patient who was with us for quite some time. quite a bit of challenges, but he managed to walk out of the hospital yesterday. So the patient is called Ian. He's a 74-year-old male who had presented in our facility on the 8th of August after having complained of fever for 3 weeks and progressive shortness of breath for the same 3 weeks. His only comorbidity was hypertension that was well controlled on nifedipine. So at examination in casualty, he was sick and in obvious respiratory distress. His blood pressure was slightly high, 142/93, but his pulse was 114 beats per minute. He was tachypnic at 40 beats per minute, and his SpO2 was 60% on room air, and even with 15 liters of oxygen, the best we could manage was 74%. So the respiratory exam, apart from what we mentioned above, he also had bilateral widespread crepitations. So at that time, okay, there's a slide missing here. So at that time, we also did a blood gas analysis, and from the blood gas, the pH was 7.4. He was retaining carbon dioxide at 74, and his oxygen, his partial pressure of oxygen was 42%. So based on that, we made a diagnosis. Oh, here it is. The oxygen was 34 millimeters of mercury. The PCO2 was high at 104, and his SO2 was 82%. And this was after being put on the 15 liters per minute of oxygen. The blood test that we did at admission at that time, his HB was 12.7. His white cell count was normal, 7.1, with the normal differentials. His platelets were 289. His sodium was normal at 142 with a normal potassium, but his urea was significantly raised at 26.3 millimoles per liter, and his creatinine was 295 micromoles. His procalcitonin was 5, and his CRP was 114. So based on that, we made a diagnosis of acute respiratory failure secondary to severe pneumonia with a possibility of COVID, and he was intubated in casualty because of the respiratory failure. We put him on the ventilator, and we did a tidal volume of 500. We set the respiratory rate at 20 with a pressure support of 10 and a PEEP of 10, and the FiO2 was 100%. Initially, as we awaited for the COVID test, and based on the procalcitonin, he was started on ceftriaxone. He was put on sedation and paralysis because of the ventilation. He was put on NG tube feeding. Because of the tachycardia that did not resolve even with the intubation, he was put on amiodarone. And on the next day, we got a positive SARS-CoV-2 test. Now, before the SARS-CoV-2 test came, we had done a HRCT of the lungs, and the HRCT showed that both lungs had diffuse ground glass opacities with foci of consolidation and air bronchograms involving all the lobes. There was no pleural thickening or fluid collection, and the cardiac configuration and size appeared normal, and no mediastinal adenopathy, and the thoracic bony cage and spine were normal. So this also helped with the possible diagnosis of COVID, but we got the COVID test the next day. So based on this, we maintained him on the treatment that I had mentioned. And on top of that, we also put him on dexamethasone. He was put on esomeprazole, artificial tears, and low molecular weight heparin. The low molecular weight heparin, we put him at therapeutic doses, even though his D-dimers were not significantly raised. So between the 3rd and the 4th days, initially at admission, he had been reviewed by the renal physician, and initially he was producing urine with the use of furosemide. And if we just go back to the chart, you'll see that initially at admission, the creatinine was 295, then it dropped to 249, then to 172. But by the third and fourth day, by the third day, we noted that his creatinine had risen again, his procalcitonin had risen, his urea had risen, and on top of this, he was retaining a lot of fluid. So based on this, a decision was made to start him on renal replacement therapy. And the renal replacement therapy that we chose at that time was CRRT, which is continuous renal replacement therapy. And this was done for a period of 4 days. And during this time, the patient was still on high ventilator settings with an FiO2 of 100%, tidal volume of 460, a PEEP of 10. And with this, he was saturating at between 90 and 94% oxygen saturations. So just to give you a progression on how he did with ventilation, by the first day, we still had the high ventilator settings with the high oxygen saturations, but we can see that by day 5, we were able to come down on the PEEP, and we had already started coming down with the FiO2 of oxygen and still saturating at 94%. And by day 6, we had reduced to 40%. And by the 7th day, we had successfully extubated him and put him on TPIS, and he was saturating at 99%. And he was saturating at 99%. So by day 10, he had been successfully extubated 3 days ago. He was off all sedatives, but his renal functions had not normalized yet, so we're still continuing with the CRRT. And the blood gas that was done then showed that it was a good gas. He had a good blood gas. So the patient continued doing well for the next 2 days. Then on day 12, the patient now became drowsy. And when we did a blood gas analysis, we noticed that the patient was retaining carbon dioxide. The pH was 6.8, and he had a PCO2 of 115, which was quite high. And his PO2 was also high at 147. At that time, he was also hypotensive. At 76 over 38 was his BP, millimeters of mercury. And at this time, we decided to start the patient on non-invasive ventilation and also to start him on norepinephrine to support his blood pressure. However, within a few hours, we noted that his carbon dioxide retention was even more, and he was not able to sustain the non-invasive ventilation. So we had to re-intubate the patient. And this time when with the vent settings, we increased the RR to 30 in order to blow out the extra carbon dioxide. And we put his FiO2 was put at 60 because even originally his oxygen levels were not that low. So by the 13th and 14th day, he was still intubated and he looked like he would be a long stay patient. So we had a discussion with the family and we did a tracheostomy. And on the 14th day, we did a repeat COVID test on the patient and he was still positive. So therefore he remained on the vent, and all through this, dialysis was still ongoing. And if I may go back to the table, just to mention that you'll notice that his procalcitonin initially was high, and then at this point it was getting higher. And based on this, we did a blood culture that grew Klebsiella pneumonia. So based on that, we also added antibiotics to his treatment. And you can see there was marked improvement in the...
I'll ask you to...
Yes?
Sorry, Dr. Demba, I'll ask you to hurry up a little.
I'm almost done.
Trying to finish up in the...
I'll be done in the next 2 minutes. And we can see by the 16th, his procalcitonin levels had come back to normal. So, by day 20 in the unit, We repeated his SARS-CoV-2 test and it was negative. And by then he was on TP-still, the tracheostomy, and he had even started talking and following commands. And at that time, we transferred him out of ICU to HDU. So by day 35 in the hospital, he was doing much better. He was able to talk. He was able to take care of himself. He was oriented in time, place, and person. He was off supplementary oxygen and even closed his tracheostomy. The only major thing that we're dealing with now was depression because of being in the hospital for long, because of not having access to his family, and because one of the major things they're saying was that he really missed going out and basking in the sun. So just to finish up, by yesterday, patient was getting ready for discharge. We were managing his depression, both with medication and with counseling, and he was doing well. He's breathing normally, no issues, and we discharged him and he went home. So that is my presentation.
Thank you so much, Dr. Odhiambo. And this is an excellent outcome for a patient. I can imagine how hard the team had to work to get this an elderly patient who seemed to, have a poor prognosis, but to take him through a fairly tumultuous course and get out well. So kudos to you and the team for a job very well done. Allow me to invite Dr. Ian. Dr. Ian, if you're there, please try and get on soon. Dr. Odhiambo, please down. Okay, you have. Thanks. Dr. Ian, next person.
The next one.
Dr. Ian, we can't hear you. Maybe we'll move to the next person. Okay, as we try to get Dr. Ian again, allow me to invite Dr. Wambui from Kwale County. Dr. Wambui. Sorry, Dr. Ann, can you hear us? Okay, we can hardly hear you. It seems a bit noisy. Dr. Ann, we can't hear you. Okay, let's try and help Ann sort out the challenge. Meanwhile, Dr. Gilo from Isiolo County. Mute. Dr. Gilo, can you hear us? Okay, we seem to be having, some of the people seem to be having a bit of a challenge. Don't worry, we'll go on and try to get them back. So for now, I'll invite Dr. Nalianya from Kericho County. Dr. Nalianya, karibu.
Hello, can you hear me?
Yes, we can.
Okay, let me share my screen. Okay, I'll just be giving a brief presentation on Kericho County COVID experience. There was a previous presentation on the overall preparedness and the overall situation a few weeks back. So I'm just going to give a brief on the update since September 5th to 17th. So cumulatively, we're having a total of 293 cases. We're seeing significantly more males than females at around 71%. The range of ages is fairly expected. We had from around 1 month to 78 years with a median age of 33. We had 31 healthcare workers being managed for COVID since the pandemic began. We're having 43 cases with comorbidities. That's around 14% of the caseload. We're having 221 recoveries. We have managed a total of 130 patients on home-based care, and we had around 1,064 tracings of contacts, with 160 of them turning positive, which is around 54% of the contact traced. So out of the total cases we saw, we have linked others to other counties. It's around 44 cases. So far, we have not had any mortality of cases we've managed in all our isolation facilities. We only had 2 confirmed cases who died, but it was diagnosed posthumously, and they were both diabetic at that time. So for the update for last week, we did not have this presentation. So for last week, we had a total of 9 positive cases. We're having around 20 being managed in the different isolation facilities in the county. We had 7 on home-based care with 4 healthcare workers who are being managed also on home-based care. Of note is that these healthcare workers are from the different facilities in Kericho County, but we've not had any positive case from the frontline workers working at our isolation facilities. We have 0 infections at our isolation facilities. So as per last week at Kericho County Isolation, we had 6 cases in that week, with 4 being new admissions. We had 4 recoveries that we discharged. All were stable. We had no mortalities that week. So of the 6 cases, 4 had comorbidities, with 3 being cancer patients and 1 being a diabetic. Of note is that we're having a few cases that are being brought to us because they're turning positive as a prerequisite to procedures they're supposed to do. Basically, Tenwek Hospital. Most of them are from Tenwek Hospital. As they go there for different oncological procedures, they're told to have a COVID test as a prerequisite, and they turn positive, and they're sent to us for management. For the 3 cancer patients, we had 1 who had a pharyngeal mass. We had 1, 2, the other 2 were esophageal CA patients. None required oxygen or ventilatory support. Actually, all of them basically were stable, and of the 4 cases that we managed for the cancer patients, the only symptoms they had were related to their cancers, which basically were having the odinophages and the dysphagias that they had. So as per last week, we had 2 patients in the ward. So from 12 to 17, that is now this week ending, we're having a total of 12 positive cases, with 25 in the different isolation facilities in the county, with the 3 on home-based care, with 4 healthcare workers. We had 4 cases at Kericho Isolation Facility with in the past week, 2 being new admissions, and we had discharged 2 patients, also no mortalities as per that time. Of the 2 patients, we actually had a 78-year-old male and 35-year-old female, both having comorbidities, one being a diabetic and the other one hypertensive. Currently, only 1 required oxygen support. We're doing a low flow oxygen on nasal prongs. So in the ward, currently we have 2 patients. For the private sector cases, we also we're having management at Unilever Hospital. We're having another facility at James Finlay. So at Unilever, they have 3 inpatients, 2 with comorbidities and 1 without. They're all stable, and they had 2 discharges in the past week. And they have 16 patients on home-based care, which are all of them are stable, and 2 had been discharged after turning negative. And they also have 1 patient at James Finlay Hospital. Basically, that's it. So for this case, it's basically I didn't have any interesting case to present. This is just one of those patients who turned positive after the prerequisite to the procedure they were to have at Tenwek Hospital. So basically, the only thing we had to do was the patient was had basically progressive dysphagia and odinophagia, and on admission could not take both liquids or solid food. So we had to do a central line for TPN for feeding. As you can see, they were basically asymptomatic as per the respiratory symptoms, and they were not in any distress. but they were wasted and cachexic. The vitals were basically within normal. Our baseline investigation also within normal. We did not see anything much on that. So we basically managed them symptomatically, and also we were giving nutrition, and the outcome of the patient was discharged in time according to the time-based criteria for discharge. The only thing that I've noticed over the past, the only challenge I can say from the past 2 weeks, we see that we're having like 4 patients from Tenwek who need this, but once they go there, they're being told they cannot be given the care they need because they need COVID-free certification. And for that, they need to have a retesting, which we're not doing currently. Thank you.
Hello, thank you so much, Doc, for that really good presentation. I think the team is doing such a good job. I'm just concerned about these referrals from Tenwek. Tenwek is a bit of a distance from Kericho. And I wonder, is there no facility in between, or are you able to work with Tenwek Hospital to set aside a facility so that patients don't totally lose out on getting other care? If it's surgery, there are safe protocols for surgery in the context of COVID, especially where there are emergencies, like a patient is totally unable to feed. And I'm just wondering how you can work together with the management at Tenwek to try and sort out this issue. Because Tenwek is in Bomet County. So I'm wondering, does Bomet not have a facility, or what's going on?
I cannot speak for Bomet County, but I believe they do have a facility, but we're having a few patients who are basically from Kericho County who are being taken care of at Tenwek who need that. So they're usually sent back to the county of origin to do that before they can have any procedure done. I tried to reach out to Tenwek Hospital about the same because I thought maybe after 2 weeks of isolation and all that, they should be able to get the care they need. But they're insisting on a COVID-free certification, and it's a bit of a challenge for most of the patients.
Yeah, that's making the patients' lives difficult. So we will also try to reach out to Tenwek Hospital to see how best patients can be managed so that we don't frustrate the patients by delaying their care too much. Thank you, Doc, for an excellent presentation, and you're doing a really good job in Kericho.
Thank you.
So Dr. Ian, I don't know if you're there. If Dr. Ian is not there, then we'll go on and answer a few questions. Dr. Ian, that's your screen? Oh, excellent. Karibu sana. Doc, we can't hear you. Dr. Ian. Dr. Ian, can you hear us? Please call him. We can see your slides, but we can't hear you yet. Oh dear. Okay, we're trying to get Dr. Ian again. He prepared an excellent presentation on their prison experience, and we hope he'll still be able to share with us.
Yeah. Hello. Can you hear me?
Okay, our apologies. Dr. Ian is having significant technical challenges, so you won't be able to hear, but he has a really interesting presentation on their prison experience. They've had quite a challenge with a lot of infections within the prisons. He will be here to present next week. So Dr. Ian, thank you for joining us. Sorry you couldn't present, but we look forward to listening to you next week. Dr. Amboi from Kwale.
Good morning. Hello. No?
Dr. Amboi, we're not able to hear you. Okay, so I think we will just answer a few questions and close the session. We're not able to get to presentations because of technical challenges, so we will look forward to hearing them next week. I will invite Dr. Maritim to make a few comments and maybe answer some of the questions that you may have noted on the platform. Thank you all so much.
Thank you, and good morning, everybody. I just want to make a comment. I think there's a question that has been posed about whether we are flattening the curve, and Dr. Acheng made a very good presentation at the beginning. And what we have noticed is that the trend of the cases and the positivity rate seems to be declining. But she also remarked that we are not testing optimally. And from the presentations from the various counties, we acknowledge that there's a lack of viral transport media, sample collection kits, and even testing reagents within the labs. So the amount of testing that we're currently having is below what we were testing previously. And therefore, it may be too soon to say that we have really flattened the curve. Another point to note is that we go through different phases of the epidemic, and the last phase being the widespread community transmission, which we have had in Nairobi, we've had in Mombasa, and different counties will go through the various phases of the outbreak before then we can say they have peaked. So it means even within the various counties, each county needs to track their outbreak, see where the cases are coming from, identify if the cases are within clusters, or if there are people who have no known contact and are coming with evidence of COVID disease. And that's when you can say probably there is widespread community transmission in your various counties. So flattening the curve does not mean the whole of Kenya will flatten the curve at the same time. The epidemic will go through different phases. And even if Nairobi has peaked or Mombasa has peaked, it doesn't mean the rest of the counties have peaked, because cases increase from active cases that are within the various counties until such a time that a large proportion of people have been infected and therefore are no longer susceptible to infection. Then you can say you have gone through the worst. So it is difficult at this point to say that the whole country is not at risk of increasing cases. And she clearly talked about the different data from different parts of the world and different counties that are having increased number of cases. And the importance of taking this seriously is that we should not relax our public health measures. And this includes social distancing, wearing the face mask, hand hygiene, and avoiding basically large gatherings. And we need to do this until such a point that we know what is it that has protected our country from a severe outbreak that has been witnessed in other countries and other continents. So we need to still be cautious. Even for us who live in Nairobi, for us who live in Mombasa, we have to be cautious and take this at individual level, continue educating the public so that people do not let their guard down. I believe at a personal level, I believe maybe it's the masks that have made a difference, and therefore we should not throw our masks away. We need to continue wearing the mask, performing hand hygiene, until such a time we know what is it that is protecting us. Otherwise, we may stand the risk of reversing all the gains that we have made. Another comment to make is really, we know we've made a lot of investments. Some counties have built field hospitals, and therefore, even as you think of taking down your field hospitals, you need to think about what will you do in the setting of a surge. And Dr. Acheng clearly talked about reopening and potential for a surge. And we know Machakos, you have a very beautiful tent, which you shared with us again today. You need to think about where will you keep your patients should the numbers go up. If schools, for example, are reopened and other settings that have been closed are reopened. So we need to think beyond the current numbers that have declined and think about what do we need to put in place to mitigate a surge, because we've had a lot of tremendous capacity building in terms of healthcare worker. We've had a lot of investment in terms of infrastructure. And this investment should help us even when you have a surge in numbers, so that we don't start from scratch. And therefore, even for other counties that are still setting up your systems like Tharaka Nithi, your numbers are still on the increase, and therefore you need to put in place your surveillance systems to track the cases as they go up. The other comment I wanted to make was about the burial protocols. And I know the IPC team has been looking at updating the guidelines, and we'll get their feedback. And this was raised by Dr. Sudi in Mombasa, and we will address that in the new guidelines regarding burial protocols. But what is very important to remember is that even though the deceased may not be at increased risk of contact, you still need the body bags to contain any virus that may still be on the surface, and even to contain the secretions. Remember, you'll decontaminate the body by spraying JIC solution, and therefore you need to contain that, and the body bags really come into play with that regard. But let's await the burial protocols by the IPC team. I'd like to invite Prof. Anzala. He wants to make a comment. So Prof. Anzala, I think you are now a panelist and you can make your comment.
Yeah, thank you so much. This was a good presentation from our various colleagues in the various counties, and I'm glad that we can meet virtually and discuss and agree forward. There are two things about the status of what is going on. As I've said before on this forum, a virus that starts in one place and ends up as a pandemic, the way SARS-CoV has behaved, eventually that virus ends up as an endemic virus. And in the process, where there's very widespread infection all over the place, the human heterogeneity allows that virus to undergo what we call self-attenuation. And that self-attenuation, in virology, sometimes we call it viral stabilization. So the virus stabilizes to a level whereby it becomes slightly less infectious, it becomes slightly less severe in terms of causing disease, and ends up being an endemic virus. And once it is endemic, then what we shall be seeing from time to time is isolated flares or outbreaks in various localities, where you find there's an epidemic in one area, then it goes down. There's another epidemic in another area, then it goes down. We must now begin to think seriously. Lois, Sud, and the others, Teronera, who have been at this. How do we begin to transition from responding to an outbreak to responding to a virus that is now becoming endemic? That is actually now where our thinking should be. Whatever you are seeing in Europe is actually a virus that has become endemic. What they are seeing is isolated outbreaks here and there, but really now the virus is totally entrenched. It may not cause much mortality. It may not cause much morbidity, but you'll actually find once in a while, you see that flare. So the thinking now is for Mombasa, for Nairobi, for maybe Kiambu, for maybe Machakos, how do we begin to think seriously of how we are going to transition from an outbreak situation to a virus that is going to become endemic? And I'm asking that because then we must think what we do in hospitals in terms of infection control, what we do in outpatients, what we do with patients who are just walking in. So we must now shift our gear and begin to think of that. Definitely, counties have not hit the peak, and counties may take a long time to hit the peak from what I'm just observing. All right, others will hit a peak very quickly, others will not hit a peak very quickly. But for me, really, this virus is now becoming stable. It is going to become endemic. Just the way OC43 was an outbreak in 1889. They called it Russian flu, but now we know it was actually a coronavirus. It was a pandemic, eventually stabilized, and OC43 is one of the 4 common coronaviruses that cause, from time to time, it will give you a respiratory infection here and there. The same thing with MERS-CoV. MERS-CoV was a widespread in the Middle East, and now MERS-CoV is again endemic in the Middle East. So for those of us who are in it, this is my push. How do we begin to think of how we are going to transition from an outbreak, managing an outbreak, to managing a virus that is going to now transitioning to become endemic in our communities? Thank you.
Thank you very much, Professor Nzala. I think you've wrapped it up very nicely. In the short term, we have to think about surges, and as time goes on, we have to think about managing an endemic disease. So thank you all for attending today, for the discussion, for all the comments. Thank you to all the panelists for preparing excellent talks and for your willingness to share with us. We continue next week. We'll have multiple panelists again, and those who are not able to present today will join us next week. Have a good weekend, everybody.